there's a lot of important concepts with coronary artery disease. The thing that you have to keep in mind when you do have cardiac chest pain or coronary artery disease in general, aspirin and statin are like the two most important things that the patient will benefit from. Okay, obviously there are others, but aspirin and statin and lifestyle modifications. I didn't put it here, but these are the most important things that will change the patient's outcomes and patient's mortality on the long run. When we talk about cardiac chest pain, by the way, there are symptoms or signs of cardiac chest pain. Okay, there are three things that you should keep in mind. Number one, substernal chest pain. This is the description: substernal pressure-like chest pain in the middle of the chest. Number two, a chest pain that is exertional, and I will extend this by saying, if you have anything exertional, if you have shortness of breath, that is exertional. If you have ear pain, that is exertional. If you have visual disturbances, that is exertional. When you exert yourself, you get visual disturbances. Anything that you get exertional, in my mind, is cardiac until you prove otherwise. So if the patient has exertional anything at all, that's cardiac, okay? So when you have substernal chest pain, when you have exertional symptom, specifically the chest pain, and if these symptoms, specifically the chest pain, is relieved by nitroglycerin, these are the hallmarks of cardiac chest pain and coronary artery disease. Do you know what we call these when you have all these three? These are called the diamond criteria for cardiac chest pain, okay? So these are the important ones to remember to classify whether the patient has cardiac chest pain or not. If you satisfy these three criteria, it means you do have coronary artery disease, or in your mind, you have coronary artery disease for the patient. Then you have to classify them furthermore. Do they have a stable coronary artery disease or unstable coronary artery disease? Okay, and the unstable coronary artery disease is another kind of subheading, umbrella term called acute coronary syndrome. Okay, so the stable coronary artery disease, it means there is no damage to the cardiac myocytes. That's the question you're going to answer in your mind. Is there damage to the cardiac myocytes? If there's no damage, which means this pain is only exertional, doesn't come at rest, then this is what we call stable angina. And it's very important to remember, in stable angina, a lot of people saying, okay, you have coronary artery disease and you have stable angina. Should we do anything about this in terms of like medical therapy or cath and revascularization? So they did a big trial. Actually, it's you should know this trial. It's called the Ischemia Trial. The Ischemia Trial, it was published in New England Journal of Medicine 2020. And what they did is they got patients who have stable angina, and they divided them, and half of them did only medical therapy, and half of them did cath, and they revascularized as needed. So they did a left heart cath. They saw if there is coronary artery disease, actual coronary artery disease, and they stented it or whatever. They revascularized, and they saw there is no difference, but medical therapy was almost superior to cath and revascularization, because cath revascularization has its risks. It's a procedure. So the important thing to know is that if somebody has stable angina, don't feel compelled that you have to send them for like cath and do all the workup. All you need to do is aspirin, statin, and lifestyle modifications. So these people you manage medically, easy. What you're going to see in the hospital are these people. The people with cardiac myocyte damage who have acute coronary syndrome. Acute coronary syndrome just means that the patient's symptoms are coming at rest. It's not exertional anymore, which means there is a fixed damage. The supply of blood is not meeting the demand of the heart even at rest. So the next step here is to look at the troponins. Why do we look at the troponins? Because that will determine whether you have actual cardiac myocytes that are dead or not. If the cells are alive, so negative troponins, then this is what we call unstable angina. While if there's positive troponins, this is what we call myocardial infarction. It's actual MI. Okay, so any positive troponin is essentially a myocardial infarct. There's cells that are dead. And then depends on how thick, or the thickness of the damage or the dead cells. If it's a partial thickness, this is what we call an NSTEMI, non-ST elevation MI. While if it's a full thickness, then this is what we call a STEMI. Okay. Now, in terms of management, again, it's very simple, right? So we'll start by talking about STEMI. So if you do have a STEMI, then how do you diagnose it? Again, you kind of go through this algorithm, and then at the end of the day, you're going to do an EKG and check the troponins. And if you do the EKG and you see ST elevations, then that's a STEMI. And in a lot of hospitals, you call a code STEMI and things start moving, even without getting the troponins, okay? The management here is going to be revascularization, number one. Number two is the management of the MI as we manage an STEMI. But in a STEMI, then the number one thing to do is to get them to the cath lab and get revascularized. This is where we get the door to balloon time, 90 minutes, door to balloon, which means door to actually opening the coronary artery that is blocked. I mean, the pathophysiology here is that you have a clot, a thrombus that formed or dislodged. So they have a plaque that's a plaque which is the atherosclerotic disease that ruptured, and when the plaque ruptures, it just the whole thing stenoses and just blocks the complete blockage, essentially 100%. That is acute. So there's no time for the heart to recover, so you get a STEMI. So any questions about this? This is pretty simple, right? You just get them to cath, and then they can put a stent, they can do a thrombectomy, whatever they want to do. It's cardiology. Okay, this is too advanced for you. Now, if you have an NSTEMI, or if you have unstable angina, by the way, both of these things, unstable angina and an NSTEMI, the management is the same, no difference. Even though the cells are alive and dead in either or, the management is really the same. So when you have symptoms at rest, then you have either troponins negative or positive, which means either unstable angina or NSTEMI. Then the management is more or less the same. So in your EKG, you might see non-specific changes. You're not going to see an ST elevation. You're going to see some ST deviation, which means either it's depressions or T-wave inversions. That's what you might see, or others. Okay, and when at this point, the management of all these MIs, when we see MI management, it's really more or less the same. Remember these orders, okay? You're going to order an EKG on your medical records. You're going to order a troponin, and you're going to order a TTE, transthoracic echo. Why? Because this will determine what you're going to give the patient if they have either heart failure or not, if their EF is 40% or not. Because the first step of management of an MI is actually anticoagulation. And once you diagnose somebody with an NSTEMI, even with unstable angina, you should probably put them on a heparin drip for 72 hours. You might not have the luxury to do that autonomously as a resident. And you might need to talk to the cardiology fellow before initiating these things. But this is the right thing to do, per the guidelines, is to put them on a heparin drip for 72 hours. And then you're going to start them on dual antiplatelet therapy. So you're going to give them aspirin and Plavix, which is clopidogrel, or ticagrelor, or others. There's other antiplatelet agents. You should probably know the generic names, by the way. So Plavix is clopidogrel, and then Brilinta is ticagrelor. There are others you might need to remember, but it's not necessarily right now. One little tip here is that sometimes these people with NSTEMI, eventually they need a cath. And when you want to cath them, a lot of the attendings, the cardiology attendings, they don't like them to be on dual antiplatelets until they do the cath. for some reason, like risk of bleeding or whatever. And so you might not have the luxury to start them on both. So again, this is, despite this triple therapy, heparin, aspirin, and another antiplatelet agent is the standard of care. A lot of times you might need permission, so to speak, from the cardiology to say, can we just start it now? Or should we wait until you cath the patient? If they're going to be cath like tomorrow in the morning, maybe you can wait because it's just an NSTEMI. It's not really a STEMI. If it's a STEMI, I would just kind of do all these. Usually what happens is that cardiology will take over. If it's a STEMI and you don't deal with it as a resident. But if it's an NSTEMI, you have more kind of leeway to do things yourself, okay? One thing to remember is that clopidogrel, Plavix, is the most famous one because it's cheap. You can get it for like $25 at Walmart for like a month or so. But ticagrelor Brilinta is a little bit more expensive. There are some differences in GI bleeds. Actually, we used to think that ticagrelor has less GI bleeding complications compared to clopidogrel. Nowadays, there's more research saying that Plavix is actually superior in terms of GI bleeds. So Plavix is the treatment of choice in general. Okay. So you did the heparin, aspirin plus Plavix. The other thing you need to remember is beta blockers. So these people who have MI or acute coronary syndrome, they have to be started on beta blockers before they get discharged, okay? The only time you would not start them on beta blockers is if they are in acute heart failure. If the MI that got them the chest pain precipitated acute heart failure and they became short of breath, pulmonary edema, whatever, then you wouldn't do beta blockers at that point. You would wait until they're out of heart failure. But if they just have acute coronary syndrome, which means unstable angina or NSTEMI, then you will have to start them on beta blockers, okay? And the treatment of choice here is metoprolol. And remember when we talked about metoprolol, there's two types. There's the tartrate and there's a succinate. The tartrate is the short acting, which is what we call Lopressor. This is not the one that reduces mortality. It's this guy, the succinate or the Toprol XL. It's long acting. This is the one that reduces mortality. And then you're going to start them on this before you discharge them home. Okay. You usually start low, like 12.5 or 25 milligrams, then you go up to 200 milligrams daily is what's recommended. The other choice is Coreg or carvedilol, which is a non-selective beta blocker. In fact, in heart failure, at least, carvedilol is superior to metoprolol succinate. But depending on your hospital, depending on your attending, some people will like toprol, some people will like Coreg. Overall, there's no big difference. You know, it's a little superior, but there's no big difference. And then, as I mentioned, statin. Everybody needs statin. And when we talk about statin, we talk about high-intensity statin. And high-intensity statins are a bunch, but the ones you should know is either atorvastatin, 80 milligrams. That's the specific dose, because this is the high-intensity dose, or rosuvastatin, 10 milligrams, okay? Again, there's no runaway here in the US. You have to remember, unfortunately, you have to remember the stupid generic, the trade name. So atorvastatin is Lipitor, and rosuvastatin is Cristor. People will not know Atorva, they will know Lipitor. I'm on Lipitor. So remember Lipitor and Cristor. And then very important here is an ACE inhibitor. By the way, this kind of cut off. Hold on, give me 1 second. Okay. You can see it? And then an important point is the ACE inhibitors or angiotensin receptor blocker. Okay, it's either or. And this one, we use it usually only if the patient has an EF of less than 40%. Remember when we did when they showed up in the beginning, we did a TTE. And the whole reason to do the TTE here is to figure out whether their ejection fraction is less than 40% or not. And if it's less than 40%, then it's indicated to start them on lisinopril or valsartan. okay? And this is essentially what you do. So again, these patients show up, they have acute coronary syndrome or an STEMI or an unstable angina. When they are discharged, remember, they're going to be discharged on what? They're going to be discharged. First of all, they got the heparin for 72 hours. They're going to be discharged on aspirin. They're going to be discharged on Plavix, beta blocker, either Toprol XL or Coreg, high intensity statin, and plus minus an ACE or ARB. Okay. I put a little tidbit here about another medication that is very closely related to the ACE and ARB called Entresto. Again, this medication you should know because nowadays it's essentially the guideline. We don't use it for acute coronary syndrome just yet, but it's used for heart failure. And Entresto is better than ACE inhibitor in superior to ACE inhibitor in heart failure. And what Entresto is essentially a combination medication. It's a valsartan, which is an angiotensin receptor blocker, and this other medication called Saccubitrol. So what is Saccubitrol? Saccubitrol is a medication that inhibits an enzyme called neprilysin. Okay, so what is neprilysin? You know, probably, I don't know if you ever heard of it, but you know proBNP, right? So proBNP is a natriuretic peptide, brain natriuretic peptide produced by the ventricle. When the ventricle is expanded, is volume overloaded, then it releases natriuretic peptide. So it's essentially a diuretic. So what you want to do is you want to increase this natriuretic peptide because it's good for the body. It increases diuresis and improves like kind of overall cardiac function. And so neprilysin is the enzyme that degrades proBNP or BNP. And so Saccubitrol inhibits this enzyme and thus increases the amount of proBNP in the body. And this in turn improves mortality in patients with heart failure. Okay. Okay, cool. So just to kind of review, so for your assessment and plan for somebody presenting with acute coronary syndrome, this is a sample assessment and plan. It's not complete, but just in your mind, this is going to be the sample. This is a 65-year-old man, for example, with diabetes, hypertension, hyperlipidemia. So these are the metabolic syndrome things. Presented with, I put, by the way, here, there's few things you might see, some short abbreviations. You might see like C/B is complicated by, A/C is anticoagulation. These things you might encounter. So PW is presented with, CP is chest pain. Okay, so presented with chest pain, secondary to NSTEMI. So this is your assessment that this patient has an NSTEMI, right? How did you know it's an NSTEMI? In your problem number 1, they have positive troponins. There's 2-wave inversion on the EKG. So he was started on heparin drip for 72 hours. You put the date of start, loaded with aspirin and Plavix, and you did a TTE that got an EF of this percent. You started atorvastatin 80, and the beta blocker is depending whether the patient is stable or unstable, has heart failure or not. And then finally, ACE inhibitor if the EF is less than 40%. And very important is to get them to outpatient cardiology, because cardiology might do a left heart cath while they're inpatient, but they might also say, let's just have them see us as outpatient, okay? And then finally, you wanna manage their other things, right? You have your diabetes, they're on metformin, you're holding it, then you wanna, you're managing them with the insulin as we talked about, and then you're managing their hypertension, and then finally the hyperlipidemia. And the disposition just pending, the rehab. If they need to go to cardiac rehab, then you have to talk to the PT and OT people. Okay, but in general, this is how you overall manage somebody with acute coronary syndrome or coronary artery disease when they present to the hospital. Okay. Any questions about this one? Okay, awesome.